everybody. Today's presentation is a demonstration of how data analysis can be used for maximizing efficiency and cost containment in healthcare. So in an era of diminishing margins, cost containment is the holy grail that administrators are seeking in order to help their systems survive. Data analytics helps us to identify and focus our resources on the chief drivers of cost. In this analysis, there are two health systems. I will refer to them as System A and System B. And taken together, we can assess the impact of comorbidities as well as disease states on cost. So with that information, the leadership can allocate resources on the greatest deficiencies that are driving cost. The first data set is from Health System A. It is an examination of BMI versus cost across all weight classes. The average cost of healthcare with respect to BMI is $3,800, and as the data presents, the highest cost of healthcare is incurred by patients with BMI over 39. They cost the system $1,400 over the mean, and this represents the highest cost difference across all the comorbidities that we will examine in this system. Second in System A is data with respect to smoking. The weighted average cost of healthcare with respect to tobacco use is $3,700. Unsurprisingly, those who never smoke incur less cost than average. Former smokers are essentially at the average, and smokers exceed this average by $800. Continuing with System A, the proportional average cost of healthcare with respect to exercise frequency is $3,700. This cost inversely declines with exercise frequency, so a member who never exercises or exercises minimally costs the system $500 over the average, and a member who exercises daily and regularly costs the system $400 less than the average. The national data indicates that regular engagement with the PCP reduces cost, hospitalization, and ED utilization. This data set, however, does not match this trend, but does show a modest cost reduction for moderate risk patients, and engagement with the specialist shows no cost reduction. So the cumulative risk score can be taken as a close surrogate to see the impact of disease states on cost. So in this system, the high-risk patients account for twice the cost of healthcare as compared to the moderate risk patients, and quadruple the cost of healthcare versus the low-risk patients. Oh my God. Oh, these are just further bifurcation. So now let us take up the individual disease states that make up the risk score. Amongst them, heart disease yields the greatest cost difference and produces the greatest cost overall. That is followed by COPD and then by chronic kidney disease. Now this brings us to Health System B. One of the highest drivers of cost in healthcare is hospitalization, and amongst the three top diagnoses that drive hospitalization are heart disease, cerebrovascular disease, and COPD, and amongst the three major comorbidities that lead to these disease states are smoking, diabetes, and obesity. So this system mirrors the national trend in that heart disease produces the greatest hospitalization, followed by cerebrovascular disease and followed by COPD. However, the rate of hospitalization as compared to the national average is higher for all the counties studied across this system. And as you can see, Berks County has the worst performance with respect to hospitalization for all the three diagnoses. An assessment of comorbidities indicates that this system has the highest prevalence of smokers as compared to the national average. The prevalence of diabetes is relatively closer to the national average, and the occurrence of obesity is lesser than the national average. Engagement with the PCP is better than the national average, but has not led to any improvement in the rate of hospitalization or improvement in diabetes or the other comorbidities. This is contrary to the literature, which indicates that regular engagement with the PCP should improve all these measures. So, what are the conclusions that we can draw from the two systems taken together? First of all, the major cost drivers are the disease states of heart disease, cerebrovascular disease, COPD and CKD, and the major comorbidities are smoking, diabetes, obesity and lack of exercise. From medical literature, we know that these are closely related to the disease states that drive cost. Guideline-directed medical therapy and chronic care management can help to reduce costs based on evidence-based healthcare literature. Both the systems will benefit from their implementation. So, guideline-directed medical therapy reduces costs by implementing evidence-based protocols that mitigate disease progression, and chronic care management maintains regular contact with the patients through primary care or nurse outreach so that to help identify patients who may be decompensating so that interventions can be put in place that prevent hospitalization. Besides that, the regular evidence-based programs implemented through primary care can help to promote exercise, weight loss and tobacco cessation to prevent high-cost disease states like heart disease. Both the systems did not match the national trends which show the benefit of primary care hospitalization in cost containment. So one of the reasons for that could be that how it is read and measured and interpreted. Say in healthcare system B, the primary care engagement is measured by just one routine care visit every 2 years. So that may just not be enough. All primary care is not equivalent. So both the systems will benefit from an emphasis on preventative care such as tobacco cessation to prevent, as a part of every primary care visit, to prevent high-cost disease states. So to summarize, data analytics can help us identify the chief drivers of cost in the health systems that employ us as leaders. We must introduce evidence-based techniques like GDMT and CCM and target them in locations like Berks County where costs are particularly high, and also implement evidence-based programs through primary care to prevent high-cost disease states like heart disease. That is good medicine and good business. These are some of the individual graphs for clarity because I put them together. Thank you.